Okay, so perhaps I'll go ahead and start. Thank you, Taryn. Elizabeth and I are happy to be here today to share the work we have been doing as part of our Seniors Health and Wellness Village at Peel Manor within the region of Peel, particularly focusing on optimizing interdisciplinary team care rounds. We will be reviewing the current challenges in supporting seniors living with dementia in the community, provide a quick overview of our integrated care model, and a description of our interdisciplinary team care rounds. Elizabeth will share specific tools and learnings from implementing the interdisciplinary team care rounds, such as the use of a streamlined communication tool, development of engaged partnerships, and some of our learnings on overcoming challenges from previous iterations of this model. Now, the goal is for our participants today to learn to appreciate and recognize the value of integrating health service partners to work as one team across organizations in the community through improved communication and complex problem solving. Really looking at how we work together. With the region of Peel's seniors population expected to more than double by 2041, traditional long-term care will not be able to meet the growing demand for seniors care. Additionally, we know for every 5 years past the age of 65, the risk of developing dementia doubles, and 61% of seniors living with dementia live at home. So compared to other Canadians over the age of 65, seniors living with dementia spend 2.5 hours more time in the emergency department, have 65% higher hospitalization rates, are 1.5 times more prone to a hospital harm, and have caregivers that experience approximately 20% more levels of stress. We also know that 1 in 9 newly admitted long-term care residents potentially could have been cared for at home. So some of the gaps or barriers in the community and service include difficulty navigating the healthcare system. So this could be challenges around who to contact, what services are available, the amount of time required to coordinate services, and really the lack of continuity across the system. It could also be financial barriers because we know publicly funded home care does not necessarily always cover all the costs associated with caring for someone at home. And some families experience significant out-of-pocket expenses. Other things can include responsiveness, the need for services that are flexible to the changing needs of the person receiving care. So that's especially as the needs evolve with the progression of dementia. And then access to specialist services. This may include specialist geriatric services or more social and emotional support, really tailored to the language and cultural needs of an individual. Peel Region is developing an integrated care model to address the current gaps that exist in delivering care for seniors living with dementia in the community. So as most Ontarians would prefer to age at home, this model incorporates seniors-focused primary care, a neurobehavioral subspecialty service, expanded adult day services serving up to 90 clients per day, an 8-bed short-stay respite care center, among other features. It will be based out of our newly built Seniors Health and Wellness Village, which we refer to as the SHWV. With the evidence from the Program of All-Inclusive Care for the Elderly, or PACE model from the US, principles of wraparound care and interdisciplinary team care rounds are garnered for proactive problem solving amongst integrated community team members working as one team. Now, the integrated care model has been, as I said, informed by the PACE model from the US, but also learnings from the High Intensity Supports at Home Plus or HISH Plus program, which Elizabeth will provide more details a little later on in the presentation. And this is where services were fundamentally restructured to enable wraparound care. Also, IDT care rounds or interdisciplinary team care rounds was demonstrated through this iteration. Now, IDT Care Rounds is a group of regulated and non-regulated health professionals that foster proactive discussions regarding complex client and caregiver situations. The IDT utilizes a standardized communication tool to streamline discussions with the most relevant information presented to achieve those person-centered outcomes, which really are above and beyond a shared care plan. So this collaborative network fosters capacity building among providers, supports those living with dementia and their caregivers. The goal of the IDT care rounds within our integrated care model is to reduce health inequities by ensuring services are individualized to meet the needs of each client and caregiver. Transform care through a person-centered lens, really looking to reduce reactive planning, improve value and service to reduce avoidable emergency department visits, hospitalizations, and avoid or delay long-term care admissions to decrease health system pressures. To enhance care provider experience within this network by maximizing skills and expertise for problem solving and leveraging technology to reduce administrative burden. We are focused on investing in community partnerships and are intentionally shifting the way we deliver services, communicate, and collaborate to delay or avoid unnecessary admissions to the ER or premature admissions to long-term care. So by changing the way we think about service integration, we can modernize our approach to improve the way we organize and deliver care and services. Now, the outcomes of our IDT care rounds have been evaluated through our adult day service client and caregiver surveys, provider focus groups, reviewing modified caregiver strain index scores, and monitoring of rostered clients that are reviewed at rounds to evaluate the reductions of situations presented weekly. Overall, the IDT care rounds have demonstrated reduced or delayed transfers to long-term care, mitigation of client and caregiver crisis situations, reduced caregiver strain, and improvement of caregiver well-being. Streamlined communication and tools have also contributed to role clarity, timely referrals, and shared problem solving.
We piloted 2 iterations of an integrated care model, with the first launched in January 2020 called PIC, Peel Integrated Care. Here we utilized a subset of existing Peel Manor EDS clients to demonstrate the benefits of wraparound supports and consistent collaborative conversations. We negotiated with home and community care support services for in-person support for a consistent care coordinator, so the same individual, and we leveraged the care conference concept, which was an existing practice and only utilized as needed, to demonstrate interdisciplinary team practices in which clients and caregivers were also included. And lastly, we trialed weekly 1-hour care rounds. By March 2020, the pandemic caused a halt to our iteration and project, in which all staff pivoted to support wherever redeployed. Then in 2021, we demonstrated a second iteration in collaboration with the Central West OHT to partner with William Osler Health System, Canes, Peel Senior Link, and Etobicoke Services for Seniors. This was the High Intensity Supports at Home program based on one-time provincial HISH funding allocated to Home and Community Care Support Services Central West to support hospital and community-based clients waiting for admission into long-term care. Here we leverage the learnings from the first iteration to inform a new way of collaborating with partners mutually invested in person-centered outcomes, as well as providing services to the same clients. Clients and their caregivers were provided access to virtual adult day programming, neurobehavioral geriatric services, social work services, access to community paramedicine, and access to a dedicated care coordinator. The IDT was formalized and included internal and external health service providers. For example, a PSW agency supervisor participated in weekly rounds only for the client or clients their agency was providing services to. Here they were updated or provided updates regarding situations in the home. This was the platform to address situations or discuss support strategies in a timely manner that would promote proactive, person-centered outcomes. To ensure seamless communication and delivery of wraparound care, a standardized communication tool was implemented and key roles were established to enable efficient use of provider time. The SBAR, an acronym for Situation, Background, Assessment, and Recommendation, was introduced, including the role of an IDT facilitator a scribe, a scheduler, and an aligned care coordinator from home and community care support services. To date, this SBAR and these roles continue to be the standard of practice for our integrated care model. So here's a fun fact. The SBAR dates back to the 1940s, originally developed in the US for the US Navy, specifically for nuclear submarines, and then later introduced for aviation, and then adopted in healthcare by the 1990s as a patient safety tool. And this was to reduce communication errors, help organize and deliver critical information in a clear and structured format. So while this approach is widely used in acute care and long-term care settings now, its use in the adult day services context at Peel Manor is the primary communication framework utilized by IDT as a mechanism to enhance quality of care for clients and their caregivers, reduce miscommunications, and improve accuracy of information exchange. So think about the SBAR framework as an elevator speech. The SBAR helps frame the most relevant information you want to tell the receiver in the most objective way. So there's no assumptions made. Facts are given. The IDT Care Rounds follow a weekly roster in which partners within the circle of care participate virtually for 1 hour every Thursday morning. The IDT rounds are led by a facilitator who ensures optimization of the SBAR among IDT members. We also have a resource that manages the weekly client care round roster, or the schedule, and also moonlights as our scribe, which is an integral role, and during all care rounds, and is responsible for documenting all SBARs presented. And so this is done over MS Teams, where the scribe shares screens so everyone can see the information that's being documented and captured. And the aligned care coordinator from home and community care support services acts as the conduit of communication among other care coordinators and IDT for those following clients at ADS at Peel Manor. I'd like to quickly walk you through the SBAR, sort of an SBAR example right now. So this is an example of an SBAR template that our project team developed and implemented for IDT Care Rounds during HISH Plus and continue to utilize to date. The tool is set up in a manner where client PHI, or personal health information, is safeguarded, and only de-identified client information, like the home and community care BRN number, and the Alaya Care client number, is utilized. And Alaya Care is our EMR that we use, the medical record. The tool provides space for up to 4 situations to be discussed, and the facilitator ensures that any SBARs presented are fully completed, starting at S and ending at R, to ensure a cohesive flow before a second situation is presented. Know that jumping from situation to situation only creates confusion and disorganization, and it's an inefficient use of providers' time. So let's take a look at Mrs. Singh here. So the situation: what do I want to tell you about Mrs. Singh that is really worrying me? And in the background, what relevant information do I need you to know about Mrs. Singh that will help you understand why I'm bringing this concern forward? Within the assessment, what do I think is happening with Mrs. Singh related to the situation that I just brought forward? And so here, I'm worried about the risk of food insecurity. And so for the recommendation, what am I recommending to IDT that can support Mrs. Singh related to the situation? So we're really applying critical thinking to eliminate any assumptions. And we're also thinking beyond the walls of, just within the group, looking at external referrals as well. So in this section, we're bringing forward recommendations that will help mitigate the risk or any crisis. In the action section, this is where IDT discusses the actions and timelines, and then collaborates in assigning the follow-up. In this model, it's not one discipline who takes on the follow-up of all actions, yet it's balanced to deter from scope creep and ensure that the right provider is addressing the right referral at the right time. To secure PHI, all client SBARs are stored in a secure SharePoint site with limited access for IDT partners only. The IDT Care Rounds roster is limited for health service partner access only, which enables their autonomy and also to arrive prepared at the weekly rounds. For the SBARs presented at rounds, they are securely uploaded to the Alaya Care client file and securely sent to home and community care support services via a secure eFax for uploading to HPG. So we are committed to partnering with our clients and their caregivers, our funders, and our academic organizations to further implement our integrated care model and interdisciplinary team practices. We believe that we can truly impact the care seniors receive in our community through partnerships. We have various partnerships that contribute to the development and sustainability of our model, which include established, naturally occurring partnerships and those in development. Partnerships are a key to integrated care, and as a collaborative network, the mutual goal is to remove system pressures that lead to improved person-centered outcomes, help tell the story once, and support aging at home. A key success to our established partnerships was our Peel Manor ADS team and the onboarding of the aligned care coordinator from home and community care support services. Without this achievement, our iterations could not have succeeded. Our naturally occurring partnerships are those reciprocal partnerships with service agencies or organizations where referrals are exchanged because of the elevated scope of specialized services offered that are specific to meet the client or the caregiver's needs, such as BSO services through the Alzheimer's Society, our PRCs, external inclusively diverse ADS partners in health and social care, as well as academic institutions. And we continue to develop and expand our partnerships with our internal and external LTC partners to help support seamless transitions as needed. Before we end this morning, we wanted to share some key challenges and recommendations we faced while implementing our integrated care model and interdisciplinary team practices. The lack of sustainable operational funding does pose difficulties for planning and can impact what you are trying to deliver. Taking the time to pilot new practices or services demonstrates your journey and supports the story that you want to tell others. Continue to iterate and build your story with solid performance measures, as this will continue to pave the way to secure opportunities for future funding. Our systems are heavily fragmented, impacting sharing of timely and relevant information that could strengthen outcomes and mitigate risk for human error. Be comfortable to collaborate and explore what's out there as a best practice and learn about the benefits in incorporating or leveraging tools that support the mutual outcome. Reduce redundant and outdated practices that do not serve an efficient or sustainable purpose. Implement a single technology system that allows for seamless communication of client information in a timely fashion, accessible by IDT members. The lack of digitally secure integrated processes and tools can present an increased risk for privacy concerns. So collaborate with your partners to ensure that ethical practices remain at the forefront of planning and implementation for safeguarding PHI. Accountability is key, so don't hesitate clarifying roles and responsibilities among partners. Teams work best when they are cohesive, and this is why we have a facilitator ensuring cadence of coordination of rounds, a scribe, and the follow-up of all actions of IDT. To ensure ongoing sustainability and effectiveness among IDT, dedicated resources are essential, so don't hesitate advocating for what you need, but be sure to leverage the evidence to support your efforts. Our roadmap was a testament of this. And lastly, we know that specific provincial data must be collected and reported, but we don't always understand what the data is telling us. Integrated care requires a person-centered story, so collect measures that are useful and contribute to telling that story. Karen and I want to thank you for providing us the opportunity to share our work regarding the benefits of integrated practices, interdisciplinary teamwork, and person-centered outcomes. Karen, I will turn to you to review if there's any questions in the chat. Thank you.
We don't have any questions in the chat as of yet, but if you do have a question, please put it in the chat or unmute yourselves. We're happy to answer.
All right, great. Thank you so much both for your presentation. That was excellent. Yeah, and again, here we go. We have a question from Christina into the chat. She says, you mentioned up to 90 people participating in ADS. Is this all in one space?
I'll take the first stab at this, Elizabeth, then you can kind of add on. So we are looking at building an expanded ADS. So it's 90 individuals per day. We are moving into a new building, Seniors Health and Wellness Village. So we are looking for 90 individuals in one day, in one space. So we are looking into hiring more staff to support this. Elizabeth, if there's anything additional.
I was going to also mention that we do have both morning or day programs, and then we also offer evening programs. So that's how we will be able to support up to 90 clients.
All right,
and
great.
Thank you, Jennifer. Spaces can be adjusted to accommodate small and large group programs. That's one of our supervisors. Thank you.
All right, great. And we'll give another minute just to see if any other questions comes in because you shared a lot of great information there. Oh, there we go. We have a question from Cheryl. What is the role of your Ontario Health team?
The role of our Ontario Health team, it's very important. So we do work with our Ontario Health team whilst we are developing our integrated care model. We work with the various partners that are part of the team to provide feedback. We leverage their resources. Elizabeth talked about in establishing our partnerships, whether it's with William Osler, Home and Community Care. So they certainly are an integral component of the work that we are doing.
And I actually have a question as well. I know I saw that one of the challenges that you find is really sustainability. And so there was a lot of like pilot projects and things, funding wise that you were applying for. And I guess I'm wondering what are your plans, moving forward for the future?
Yes, sustainability is absolutely one of those key components of any sort of program that you're developing. And so we do continually look for funding opportunities. And as Elizabeth stated, as part of developing something that is sustainable, we really have to demonstrate our metrics, our evaluation, and really the value of what we're doing. So we are certainly using that iterative approach to do so.
All right, great. Thank you. And we have a question from Ray.
Yeah, it's just more of a comment in terms of the relationship. It's a very close working relationship. I do serve on the Central West Collaboration Board, and I just want to say that we endorsed, as our two guests here noted, not only the HISH Plus program and provided financial support through the OHT, but also the program they're now referring to, which is sort of fully integrated healthcare service. We're very excited about it. A number of us are partners in the work of the program, but the OHT is on record and has endorsed the work that the regional field is. I just want to congratulate the two of you on an excellent presentation. Thank you.
Thank you, Ray. Thank you. Thank you, everyone.
All right, and we have another question in the chat from Kimberly Martinez. These ADS spaces, are they available to community or clients attending long-term care?
So the ADS spaces are for community, and it would be through the process of home and community care support services that you would generally apply to. The ADS spaces are not for long-term care, but there is a lot of integration of programming and shared spaces within the SHWIV where long-term care and our ADS clients would be interacting.
All right, great. Thank you, Elizabeth. I'm not seeing any other questions. So if you have any burning questions, Kimberly says, can I connect with you afterwards?
Absolutely. Absolutely. We would enjoy it.
All right, great. Perfect. And Ray, you have your hand up again?
Yeah, I'll just be quick. Just a follow up because of the question. Another opportunity that arose because of this is the relationship between our services, which are assisted living services on Peel campus, and the adult day program. We've already been sending adult day program residents to that program in partnership, but we are delighted to know that spaces are being expanded. So I just want to put that out there because we've sort of heard about the PACE and PACE-like models, and really the adult day program, for those of you who've traveled to the US and seen the model, is very much at the center of the work that they do and all the other good work that has been identified by our colleagues. So I just want to give you a small example of one agency working with this program in a way that people can best be served in proximity. So I just want to put that out there for consideration as you develop your PACE-like models.